everyone. Welcome to another session of Figuring Out Fertility. Today we have Dr. Tom Hannam, who is the founder and medical director of Hannam Fertility Center. Thank you so much for being with us here today, Dr. Hannam.
Oh, Vidya, thank you again. And thank you to Fertility Matters Canada for putting these on.
Great. So as everyone knows who's watching, it's Canadian Infertility Awareness Week, and all week long we're bringing you great content from professionals across the field dealing with your medical health, your emotional health, and the theme of this year's CIAW is Find Your Joy. And while that's a very complicated theme in the fertility journey, part of being able to find that joy is hopefully a successful outcome from embryo transfers. So today we're going to talk all about everything you need to know about embryo transfers. We've gotten a lot of questions and we're just going to hammer through them, and Dr. Hannam's going to answer all of our questions for us.
Okay, good plan.
All of them.
Okay.
Okay, great. So talking about maybe why don't you define embryo transfers for us, just to set the context for everyone watching.
When we're doing in vitro fertilization, it's always to lead into a transfer. And historically, it was a straightforward process. Embryos would grow in the laboratory for 3 days, and we would transfer embryos. And we never knew which was the good embryo, so we would routinely transfer 2 or 3 embryos at a time. And that's why, you know, from back in the day, a decade ago, there's lots of twin pregnancies, even triplet pregnancies, because it was just such a randomizer. Now, most clinics are growing embryos out to the blastocyst stage. That means they're 5 or 6 or sometimes 7 days old. We know they're ready for implantation because they're blastocysts. That means there's an outer shell, that's the placenta. And that transfer is going to occur either on the fresh cycle, that means just a few days, you know, the 5 or 6 days after the retrieval, or more commonly a frozen embryo transfer. So the retrieval process is long gone, and you're getting set up just to do that frozen embryo transfer, which means the embryo is going to be thawed usually a few moments before the transfer itself occurs.
Great. So how long would you recommend, this is probably differing case by case, but how long would you recommend after doing an embryo, after doing an egg retrieval to do an embryo transfer?
Well, so the shortest you can wait is really no time at all. You can have a retrieval done, and you and your clinical team are planning to do a fresh transfer. There are some advantages to that. It's less complicated. You don't have to worry so much about the laboratory's ability to freeze and then thaw embryos. It's probably going to be less expensive because there's fewer steps. Couple things to think about though. One is when you're doing a fresh cycle, your hormones are all over the place, right? Because you were taking these drugs to get lots of eggs. With lots of eggs come really high estrogen levels, much higher than they are physiologic, much higher than they normally are. That's a bit hard on the lining of your uterus, perhaps. So a fresh transfer is a perfectly reasonable choice as long as estrogen levels are not too high. Some people think as long as the estrogen level is less than 8,000, then maybe a fresh transfer is a good idea. Another complexity of fresh transfers is that sometimes it takes 5 or 6 or 7 days for those embryos to become blastocysts. In other words, sometimes it takes a little longer for the embryo to become ready than where the person's optimal window of implantation is. So it can be a little confusing, make for some complicated decisions on the day. Those are the pluses and minuses of the fresh transfer. So, but to answer your question, how long do you have to wait? The answer is fresh transfer. You're not really waiting at all. You're going right into it. And otherwise, you could really go into it your very next cycle. You could have menses and go straight into your frozen embryo transfer.
Okay. Is there an advantage at all to waiting a little bit longer, or
the advantages
at all with your embryos?
For sure. So the good news about working with frozen embryo transfers, whether it's your first transfer or perhaps you're into the process now, the good news is you never have to do your embryo transfer. It doesn't have to be this cycle or this month. You might want it to be, but it's not a medical requirement, which means the timing should be truly what's best for you as an individual. And I don't know, none of us know how much stress impacts anything around this process, but one thing's for sure, Going through a fresh retrieval is a stressful process. It just is. But going through a frozen embryo transfer, it can actually, I hope, can really fit with your lifestyle, with you, your emotional space. And you should never go through until you feel physically ready. So your clinic's going to do a few things trying to make sure your body's ready, but you can also just check in with yourself. If it's feeling like a rush, then don't do it. If you're feeling like you're getting a bit sick, then don't do it. If really, honestly, if the moon doesn't look quite as high as it should be, like, I'm being silly, but my point is that anything that doesn't feel optimized, don't go to that cycle. Go to the one that you feel ready.
Great. Okay, let's talk about the actual transfer cycle.
Okay.
So can you walk us through the transfer cycle? Like, what kind of drugs are being used in a transfer cycle, and how hard is that on your body?
Yeah. So when we're doing so now we're going to talk about, should we focus on the frozen embryo transfer? Those are the most common transfers.
Yeah, I think that makes sense.
Okay, so when we're doing a frozen embryo transfer, what we're trying to do is just match your normal hormone levels. That's it. So there's a couple of ways we could do that. One is no hormones. Person just comes through with her regular cycle. And there's nothing wrong with this plan, a purely natural frozen embryo transfer cycle. Or if you don't trust exactly when you're going to ovulate, maybe you'll use letrozole to help you ovulate regularly. Or maybe you'll even use those injectables, just like you did with your retrieval cycle. You'll use an injectable hormone just to get the eggs to develop. So some version of a natural cycle. Awesome, right? It's just natural you and natural estrogen levels. It's all your body really needs. There are two big disadvantages with it, though. The first is natural cycles are not super reliable. So you never actually know when you're going to ovulate, and there's a lot of monitoring that has to happen. So even though it's natural and that's nice, you end up coming into the clinic a lot for blood tests and ultrasounds. So, and that leads me to the second problem. It's a pretty high cancellation rate. We, the clinic, despite all that monitoring, might miss the moment that you ovulate. We never know exactly what day it's going to be. Maybe you'll ovulate on a day that because you ovulate that day, you know the transfer has to be 6 days later, and that's not a convenient day for you or the clinic or something. The cancellation rate is high with these natural cycles, so it's a lot more work and a high cancellation rate. Okay, medicated cycles. There are some advantages to this. If you're going to do a medicated one, that means you're going to take estrogen. Instead of relying on your own natural estrogen, you'll take a synthetic estrogen. And there's lots of ways that we can give a person estrogen. There's estrogen patches. There's estrogen tablets. Those can be taken orally, or those exact same tablets can be taken vaginally, which is crazy, but totally works. You can just take it vaginally, which means it doesn't get, it does not have to get absorbed and then beaten up by the liver and finally get to your uterus. If you take it vaginally, it just goes straight to the uterus. So maybe there's fewer side effects with it.
You will have green pee.
Yes, true. Okay, that's true. Because the tablets were color green for whatever reason, it's not medically valid, and the green part's not absorbed, right? So your body absorbs the estrogen and the green part leaks out, as it were. But yes, so there's the patches, the tablets, there's even estrogen injections. It's literally whatever is going to be the most comfortable for you, whatever you and your doctor think is going to be the most convenient. So we will routinely use patches just because for most people, the side effects of patches are limited to irritation at the patch site, like, wearing a Band-Aid too much. It just kind of irritates the skin. But is that an advantage? Yeah, it's really great. You know that the lining is going to thicken up in 2 weeks, so you don't even have to monitor those during those 2 weeks. And not only that, it's about 2 weeks. So you and your clinical team can decide, are you going to come back in on Tuesday, or maybe Wednesday or Thursday or Friday is more convenient for you. It's all very scheduled. So it's a much lower stress experience. And particularly for people who don't actually trust their own natural cycles, it feels safer and more reliable. But there are downsides, of course. So one is your body just may not respond the same to these synthetic estrogens as they do your natural estrogen. So for some people, it just is better to do the natural cycle. And there's another downside too. The other downside is many of us, because remember, there's estrogen and progesterone, it's time to add the progesterone in. Many of us prefer using progesterone in oil to any of the other progesterones. So there are different progesterones out there. They're mostly suppositories. There are some oral tablets, but they're mostly suppositories. Take them vaginally. But absorption can be quite variable, and many of us encourage using progesterone oil injections at the same time. And these are intramuscular injections, usually in the bum. And I think it just depends on the individual, but it hurts after a while. And you often need a partner to help you with injections. And it's just one of those things. So, you know, what's better, doing those modified natural cycles or doing the medicated? I would say different. You should know that it's exactly the same pregnancy rate between the two approaches, and that most people choose the medicated just because the lived experience for most people most of the time is more straightforward. It's more reliable.
Great. Just with the progesterone and oil, I'm terrified of needles. And from my experience, it actually, I did have to get my partner to do them for me. After a while, it does kind of build up a little bit. So you just have to, there's tips and tricks on the internet on how to kind of reduce.
You mean the oil the oil builds up? Is that what
yeah, there was like a little lump. It was
there is. So you're absolutely right. The progesterone itself gets absorbed, but the carrier agent is this oil. And yes, it can, and you really do want to rub that away. I mean, otherwise it's just a pocket of oil that, I mean, worst case scenario, it'll form an abscess and you get an infection there. Like, you really do want to rub it away. It hurts. And there are some people, a lot of these oils are nut-based oils like sesame oil. So not everyone has an allergy to nuts, but you can definitely get an allergy, not to the progesterone, but to the progesterone in oil. You get an allergy to the oil. So it's not for everybody.
I actually found it wasn't as painful as I thought it was going to be. Like, the needle looks like bigger than some of the other injectable needles. So it's kind of like daunting in your head, but then when it's actually injected, it's actually not that bad. It's fine.
I'm glad you said that, Vidya. The truth is, for me, it's one of those things as a fertility doctor. I just hate it. I hate what we're asking women to go through to be able to carry a pregnancy. I wish there was a more straightforward way. And for a long time, I actually avoided using the progesterone oil just for that reason. But the truth is, it's very well absorbed. And if the purpose of this is to get pregnant, it's one of those things. It's like, you know, if we do this, it's just going to work out. So
yeah. Well, and the alternative is a suppository, and that's not fun either, right? Like,
right, because your body absorbs,
yeah.
again, it absorbs the progesterone, but then there's a ton of discharge, right?
Yeah.
And it gets pretty confused. Yeah, it's not great. There's and if you don't get a yeast infection, it feels like you're going to get a yeast infection because there's all the discharge from that. And that inflammation can reduce the amount of absorption. If your clinical team is not giving you progesterone oil and you're worried about it because you're noticing all this discharge and you're wondering, is this even working? The answer is, you can ask your team while you're on the progesterone to draw a progesterone level for you. So we know that we like to see a serum level of 15, but really we like to see your serum level of between 30 and 80. So if your progesterone's in that zone, then even if there's lots of discharge and all those things, you can be reassured that you're getting enough to keep the lining nice and stable. That's the point of the progesterone, so that the embryo, when it implants, it doesn't cause a lot of bleeding. It just can implant and stay put.
Great. So you're taking estrogen to build your lining, and then you switch over to progesterone and
add in the progesterone. Yep.
It's kind of to trick your body into thinking it's ovulated, right?
Exactly right. And your alternative is to literally just ovulate and have a modified natural cycle. And remember, exactly the same pregnancy rate between those two approaches.
I remember, this is really random, but I remember a lot of my friends going through transfers at the same time. I have so many friends who go through transfers at the same time. Yeah. But, I remember our doctor saying that, like, it doesn't matter how long you're on the estrogen.
Yes.
Right. Like, but is there a time, like, you know, at one point I was on the estrogen for like 4 weeks, 5 weeks, waiting for, like, you know, results from a test on our embryos or whatever. At any point, are we worried about, like, the lining getting, like, old or decreasing in fluffiness or whatever?
Or something? Yeah, no, you know, it's interesting. Neither like the literature nor our internal data seems to point to any problems with the range of estrogen. It seems to be okay, which intuitively kind of makes sense with what we know about natural cycles. Women do have highly variable cycles, right? So some women have 25-day cycles and others have 42-day cycles, and all of those people can get pregnant. So it's no wonder that a wide range works.
The triple line. Can you talk about looking for a triple line in the endometrial lining?
Yeah.
And why?
Yeah. So what this is actually, I'm glad you brought that up, Vidya, because this is one of the things that patients at home can, a lot, as a patient, when we're in a medical setting, we're along for the ride. Like a lot of the time, you're like, you can get these educational sessions in, but the bottom line is you're going to have to do what your clinical team is comfortable with doing. So you're just kind of doing that. But knowing what your lining looks like and is a helpful part of it. When you go through IVF, during that process, most clinics will measure the thickness of the lining of your uterus. And at the beginning of a cycle, it's meant to be 3 or 4 or 5 millimeters usually. And during the cycle, unless you're taking something like clomiphene, it'll usually get up to 7 millimeters or more. So we really like to see numbers like 7, 8, 9, 10, 11 millimeters, something like that. And when you get that on your IVF cycle, then you know that you should be able to get that on your frozen embryo transfer cycle. So when you come in on your frozen embryo transfer cycle, and you're getting that ultrasound, and your clinical team says, we think it looks good to go, it's not unreasonable to ask, well, what's my lining thickness? And everyone's going to have a different number, and anything that's 7 millimeters or more is good. And for some people, it'll be 5 or 6, and that's their number. And for them, that's their okay. And you kind of know what your okay is because you saw it when you did your IVF cycle. Okay is measured by 2 different things. One is the thickness, and the other is the appearance. So what do we mean by appearance? Well, the terminology for an ideal appearance is triple line or hypoechoic. And what that means is the glands that thicken up because of estrogen are so full of fluid that on the ultrasound, it looks kind of black. So you get this white line on the outside and a white line on the other side, and it's black in between them, except where they meet, it's white again. So it goes white, white, and white. You get 3 white lines. It's actually not that hard to see. You can Google that image, no problem. Uterine lining, triple line, and that's what it looks like. It's really straightforward. And why do we care? Just because we know it's associated with great implantation rates. This is exactly the kind of thing, Vijaya, that I really hope that AI is going to help us with over time. It's not just thickness and triple line. There must be more factors that go into deciding in an atraumatic way what a perfect lining is, but those are the 2 parameters that we have at the moment.
Okay, great. We've heard a bit about, or people have been asking about intralipids and what the value of using intralipids in your embryo transfer cycle are, and if there's any research supporting that it might be related to more positive outcomes.
Okay, so what we just talked about is just using estrogen, progesterone, and that's it, either synthetically or as part of a natural cycle. And in theory, that's all you need. And actually, for most people, it's as long as the lining looks good and the uterine structure is the right shape, so it's not severely compromised by a septum down the middle or a fibroid, and your clinical team should have worked that out with you before you were even there. You're in there saying to yourself, okay, this is the best anatomy version of me, this is the best lining version of me, and you're living your best life. You might choose to work with a naturopath who can help you with lifestyle stuff if you're wondering what your best life means. And it doesn't always work. Even when we're transferring euploid, genetically balanced embryos, it doesn't always work. After the first or second time, it certainly makes a person think, well, what else can I do? So when you're thinking about what else can I do, that's when we're talking about adjuvants. So maybe starting off with the easiest one that many people will choose to take is a baby aspirin a day. 81 milligrams a day. Does it do anything? I don't know. And is it harmful? No, not harmful. So I will routinely encourage baby aspirin as part of the process. What else can you start to add in? Well, you can add in more aggressive blood thinners than baby aspirin. They're called low molecular weight heparins, pretty aggressive blood thinners. What are they helpful? No studies have ever said they are for most people. There might be some utility in some very special circumstances. It is widely used in the fertility community as just like I said, does aspirin work? I don't know. What about, low molecular weight heparins? You can start to use these things, but the problem is you're also getting into risks now. There are real risks to your overall health when you're thinning your blood that much. Now, you asked specifically about intralipids. There's really poor studies that say intralipid infusion will help with any autoimmune problem associated with embryo transfers. Now, the immune system and implantation is not well understood. There's no perfect tests that tell us exactly when you should use a treatment, and if you should use a treatment, which one. But the fertility community has really sort of held on to intralipid infusions. And full disclosure, it's something that we do use at our clinic as well. What are intralipids are something that will give people who can't eat properly. You just give, it's like giving someone food in their IV. So the experience of an intralipid infusion is you come into the clinic, they set up an IV, you hang out for a couple of hours. You might get an allergic response to it, although I've never seen it. And they are giving you lipids in your IV. Is this safe short term? Yes, as I say, I just haven't seen an allergic response yet. You know, I presume I will one day, but we haven't seen it yet. That's how rare the complications are. People do really well with it. What's the long-term safety profile? I don't know. You know that all of us who eat well do try to, you know, keep down our saturated fats. We're not really into cholesterol. And this is the opposite of that. You are like really filling your system with lipids. So it would not be something that you would want to do every day of the week, but presumably over the short term, once or twice, it seems to be harmless. I've never seen a problem with it over the short term, and it may help for people who have concerns about an autoimmune rejection of pregnancy. But yeah, I do not recommend it for everyone, Vidya. It's just also not necessary.
Yeah, no, but the other information on aspirin and blood thinners and stuff is very helpful as well. Is HCG one of those kind of add-ons?
Yes, exactly. So HCG is the pregnancy hormone. So what if there's a scenario where somehow your immune system attacks pregnancy hormone? I mean, we're really making stuff up at this point, but in this scenario, you could start to add in some pregnancy hormone. Now, you can imagine immediately it's going to throw off your positive home pregnancy test because it's going to be positive because you were just giving yourself HCG. So it's kind of confusing 10 to 14 days later, like, am I pregnant or is it just this extra HCG that I'm taking? I used to use it quite a bit to try it out. Don't think it made any difference. It seems to be harmless, but it's non-standard care.
Okay. What does it mean if you're spotting in the middle of your transfer cycle? So before you actually get to the point where you're transfer, like, is that a risk? Is that we should stop this and start again later?
Okay, so first of all, there's two different times this could happen. One would be before you've even done the transfer, right? So you've just taken estrogen or you've added in the progesterone, and if you're getting spotting, I would almost never actually want to go ahead and do the transfer. Let's be honest, a lot of spotting is going to come from the cervix because maybe the cervix is getting irritated after those transvaginal ultrasounds or because of all these suppositories. But if there's any doubt in anyone's mind, again, just don't do the transfer. Honestly, cancel a cycle anytime until you've done the transfer. And then what are you going to do, right? It just makes me so sad for people who get spotting after we've done the transfer. Again, it might have been, I wouldn't be too fussed about spotting the day or two after transfer. You just had a speculum in, the doctor put a catheter through, that definitely irritated the cervix. So a day or two after the transfer, I wouldn't give it any thought. But like a week later, we call it implantation bleeding, and it may well be, but I'm always happier for my patients when there's no spotting at all, because who wants that weighing on their head? And if you actually have an early menses, if a full period's coming before you even got to your pregnancy test, I would interpret that as inadequate luteal support. In other words, estrogen or progesterone may not be holding the lining as stable as we would like. I would like you to be able to get to the point of at least trying to see if you're pregnant before menses start.
Okay. Probably you get this question all the time. I've asked you this question before. Can you exercise during a transfer cycle?
Anything that you decide to do, so whether you choose to exercise or you choose to have sex, or I'm not even sure what are the things that we would worry about, you're going to have to live with your choices afterwards. So what my advice is this: just consider future you. If whatever you're about to take on, are you going to blame you for not getting pregnant? Are you going to blame that? Because if you're going to blame that, whether it's staying too late at the office or exercising or having intercourse or whatever your thing is, if you know yourself, or what about getting on a plane? What about just doing a 5-hour cart, like anything? If you're going to blame yourself, I guess you can't do it. But 2 caveats. First of all, please be kind to yourself. There's no evidence for any of these things that they make any difference at all. And secondly, lots of people do exercise during this time. If you're going to, if you are, if you're not regularly an exerciser, then don't. This is obviously the wrong time to start. And if you are a regular exercise, seriously consider keeping your heartbeat below 140 beats per minute. I know that doesn't sound very high, but for most people, it'll get them out, it'll get them into their routine, which is probably why they want to exercise those 9 days. It's a stress reliever for them, and it's not going to strain the system in any material way. We're talking about 9 days, right? Most of us are waiting 9 days between the day of the transfer and when you get your positive pregnancy test. Once you're pregnant, that's different. Everyone has their own relationship to exercise once they're pregnant. So I won't address that for now. Short version, I think exercise is a good idea, but during those 9 days, you might want to just take care of yourself and don't push yourself into any new levels of stress. You're trying to, it's part of a holistic approach that's keeping the inflammation down. So you're not over exercising, you're eating low inflammatory foods, you're going to bed on time, and maybe you're taking a baby aspirin a day.
Okay. On the actual day of the transfer, what can someone expect?
Well, the first thing to know is most clinics were thawing the embryos really just as you're arriving at the clinic. It's a very last moment thing. So, so here's a worst case scenario. Your embryo doesn't thaw the way that you or anyone expected it to, and there's not going to be a transfer that day. There's no good way to deliver that news. It's just bad, and it comes to a person who's very ill prepared for it because they were planning on having their transfer. So there is no good way to do that. Thankfully, it's very rare in a modern practice. It is very rare. So what you can expect is, as you're arriving, is somebody in that building knows how your embryo is doing already. Somebody in the lab, probably. They may or may not, depends on the protocols of your clinic, they may or may not have been able to communicate it out to your nursing team or to your clinician. They may or may not come out and speak to you themselves, but somebody knows how your embryo is looking. And what you want to hear is that your embryo has expanded. What expansion means is, because an embryo shrinks down when it's frozen, and you want to hear that it's come back up again. If it's come back up again, those cells are thriving and growing. And maybe it's even gone past that and it's starting to hatch out of the shell. But the most important thing is that it's expanded. I didn't really answer your question. You asked what else can you expect, right? You can expect a lot of sitting around because it's a scheduled event, kind of, but actually the timing of it doesn't matter. And your clinician surely is going to be focusing on other people as well as you. And so what you would hope and expect is that when it's your turn, when your doctor's spending their time, when your doctor, your ultrasound team, your nurse is spending time with you, they're all in with you. There should be no sense of rush in that room. You should feel like everyone's got all the time in the world, because frankly, they do. This is your embryo transfer, and that moment, no one needs to go anywhere. Okay, you're going to need a full bladder. That's to have a healthy ultrasound, but full is not painful. Full just means full enough that the ultrasound works. It's actually not crazy full. And if you're in pain, you need to pee. And here's some crazy news. You can definitely pee a cup or two and stop. And that's not something that we practice in our everyday life. But as a fertility patient, maybe you know this already. You can pee a cup or 3 and then stop. It does take the pain and pressure away. And again, if you're in any kind of pain, you're almost certainly too full. And if you overdo it, if you go to the bathroom, you allowed it more than you were meant to, well, we're just going to wait, right? Your bladder is going to fill right back up again. So you should be comfortable. They'll put a speculum in like anytime you're getting a pap test, but this whole procedure is not a scary procedure. It is not meant to be any more difficult than a speculum and a person doing an ultrasound with your full but not painful bladder. So I don't want to minimize it. It's still a thing, but it's not a great big thing. It's not like when you did the retrieval. Vidya, we promised ourselves that we'll be pretty quick today, right? So This is a transfer I
Oh,
did.
you're not kicking me off.
This is a transfer I did earlier today. And this is what it looks like to us when we're doing the transfer. So this is the cervix here, and then it kind of opens up to the lining of the uterus. Okay. Now in this cervix, there's a white line here. That's the guide catheter that we put in place. You can see lots of things wiggling out here. That's the bowels. And that's the catheter that holds the embryo. Actually, it's going to go into the uterus, and we're going to go to sort of the top. That's the top, but in the end, you don't actually leave the embryos at the top. You leave them more in the middle of the uterus. So that was the moment that the bubbles came out, and then this catheter is going to pull back. There it goes. And what you're left with here in the middle is the bubbles. Now we're not going to see the embryo itself. It's microscopic. So when we do this, all we can look at is the bubbles. And what we're hoping to see is at the end of the procedure is something like this, where you see the cervix kind of spreads out into this nice, almost a teardrop shape. And then in the middle of that, you see this bright white part. That's where the transfer was. So that's what we're looking for when we do this. Of course, it depends on your clinic. Some clinics show you the screen in real time as they're doing it. Others will try to bend it around, but the doctor's looking at the same one. And sometimes it's a complicated transfer. There's no real way to share that image as we're doing it. You don't need to see it as it's happening. Your clinician needs to see it, and I hope will be in a position to tell you immediately afterwards how it went. But hopefully they see that, they call it a flash, that flash of bubbles, so they know exactly where they placed your embryo.
Right. That was cool. Like, I'm a little bit of a fertility nerd, so I thought that was super cool.
We're all fertility nerds. It's a very interesting space, and it's awesome when it works for people. It's always interesting though. Fertility is interesting.
I would hope that you think that. Okay. Okay, last question.
Okay.
After your transfer, what are the symptoms that are kind of just like normal that would happen anyways? Like everyone, you know, as a patient, as a former patient, super hypersensitive to every twinge your body makes. And it's very difficult to read those signs. And of course, you're always hoping that it's a positive sign, but what's normal? What should you expect? Go.
You're in an impossible position, because whether it was a modified natural cycle or we gave you estrogen progesterone, either way, I'm certain that your clinical team is going to give you a little more progesterone than you really need, just to be on the safe side, just to make sure there's enough. And that's a great thing from an implantation perspective. And if your team chooses to measure the levels, we like to see progesterone levels between 30 and 80. But you know what? A natural progesterone levels can be as low as 15. And so when you're getting levels between 30 and 80, you'll feel that. Many women will feel that. And unfortunately, the side effects of high dose of progesterone are not dissimilar to what an early pregnancy might feel like. And it certainly won't feel like you normally do on a normal cycle. So a feeling of bloatedness, of heaviness. A lot of people talk about breast tenderness, and specifically nipple tenderness, but these are all things that can also, when you look it up, these are also the signs of early pregnancy, because early pregnancy is associated with HCG and actually pretty high progesterone levels. So the two overlap impossibly. So as an individual, there's literally no way to know. There's no way to know. Are you like, is everything going well? Is it going badly? What if you don't get any of those symptoms? Maybe you're just an individual, thank goodness for you, who doesn't actually get a lot of side effects from progesterone. Nothing wrong with that. It's just you don't feel it very much. So then you're left with no symptoms at all and wondering if that's a bad sign. It really is a muddled time trying to read your own body because of the hormones that we're giving you. So I ask that you be kind to yourself during those 9 days, and keep one foot in front of the other, and know that that 2-week wait, which is what they used to call it, is arguably some of the hardest times of all in this process. And I hope that you've managed to get your people in place, your support people around you, so that you're feeling safe, because it's a long few days.
That's great. Okay, I lied to you. I have one more question. Okay. as I mentioned, the theme of Canadian Fertility Awareness Week this year is Find Your Joy. So what advice do you have for patients that you see to help them find their joy?
I think that the best part about embryo transfers is that you are in control of this part of it. Yes, you're with your clinic, blood tests and ultrasounds, but at a fundamental level, you get to decide if this is the right cycle for you. You get to pull away from that, which means because you're in control, I hope that part of what you're doing is bringing people around you to take care of you, so that come good news or bad news, you've got your community around you, whether that's a community of one, a community of you and your partner, or you've chosen to bring more people than that. Maybe you have a therapist, maybe you're working with a naturopath, maybe you've chosen to let a best friend or a sister or someone else who's close to you, or maybe a lot of people, maybe you're a blogger and that's how you deal with you. No pressure. You get to do whatever is right for you. And I would suggest to you that finding your joy through a sense of control is something that you really do get to do around frozen embryo transfers. We're powerless at the end of the day to know if it's going to work or not, but at least you can look back on this and know that you were true to yourself through the experience.
That's a great answer. I didn't prep you on that question, so that was
not prep me on that question.
Okay, well, thank you so much, Dr. Hannam. Again, you come back frequently and we're so appreciative.
I really like doing this with you guys. Once again, ridiculous setup. When am I ever going to get my game on? I feel like I'm Casper the Ghost today. I'm still at work, and we actually have set up a studio now. That's what's behind me, but I'm not sitting at it and the building turned its lights off. So there we go. Thank you for bearing with me on that. Hope the sound was good. And once again, Vijay, thank you to you and everybody who puts these things together. It's a great service that you're doing. Thank you.
Thank you. Well, to everyone watching, thank you so much for joining us. If you have further questions, please reach out to Dr. Hannam and his team. His contact information is on our Facebook page. I hope you have a great CIAW, and I wish you success in your fertility journey. Thank you.
Bye.
Bye.